Welcome to GIE Author Interview Series. For today, we have an interesting study by Dr. Raman Muthusamy, Director of Endoscopy at UCLA, and Dr. Adarsh Thaker, Gastroenterology Fellow. And the title of their paper is Inspection of Endoscope Instrument Channels After Reprocessing Using a Prototype Borescope. Welcome, gentlemen.
Thank you.
Thank you.
If you can explain to us our rationale for the study and some of the steps you took to achieve your aims.
Sure. So, since the recent outbreaks of duodenoscope-related infections, one of the quality steps that's been proposed is to actually do a visual inspection of the borescopes, not only externally as we do currently, but also internally, of the endoscopes. And so what we proposed is to systematically review all of the devices that undergo ERCP and EUS at our institution, really to identify the nature and prevalence of any findings. We hypothesized based on some initial pilot studies that we would find mechanical imperfections such as scratches of the channel lining or shredding in which actual filaments of the lining are protruding into the lumen. And we were also interested in seeing if there was any debris or discoloration, maybe related to the manual cleaning steps. And finally, we had read with interest a recent study that raised concerns about simethicone residue within the device channels. And our institution, we use ethylene oxide gas sterilization for all of our duodenoscopes and echoendoscopes. And so we were interested in seeing if our drying protocols were adequate to get rid of visible moisture within the lumen, because ethylene oxide plus moisture can create glycol byproducts. So these were kind of the background factors that led us to perform this study. And so what we did is over a 6-week period, after every procedure and routine reprocessing steps, we had our technicians run a borescope through the devices. And this was after manual cleaning, high-level disinfection, and forced air drying of the channels for our elevator devices. And we had them record about a 2-minute video. And then we later reviewed the videos for these findings that I just mentioned.
Mm-hmm. Did you have any difficulty in terms of training your staff? What were the challenges training your staff to perform the borescope exam?
Yeah, one of the main goals of this study was to implement the borescope inspection with minimal disruption to the workflow. Our staff already have many steps that they have to perform perfectly because there's very low threshold for error or margin of safety when you're doing reprocessing. So we did an in-surface exam, had example videos of prior findings, and had a training where we watched all the technicians perform the borescope exam. We also gave them leeway when they were performing videos to slow down on any findings. And so overall, it did not take much to implement it, and that was one of the findings. It was relatively easy to do. We did make some design recommendations based on that to the next generation of these borescopes to even further aid our technicians.
Excellent. So explain to us the findings, what made you surprised, any interesting findings?
Sure. Some of the findings were not surprising because we kind of had an idea from prior studies that we would see. The highest prevalence were scratches, simply defects in the channel lining followed by shredding. And then we saw a relatively equal number of leftover debris and discoloration, about a quarter of our devices respectively. And then moisture, strikingly, we did not find any moisture, visible moisture, in any of the devices that underwent a manual forced air dry for 2 to 3 minutes per channel. However, there were a few devices, out of curiosity, gastroscopes and colonoscopes, that did not undergo the forced air dry, that when we inspected those, we found a relatively high rate of leftover moisture. So overall, there were a few things with the findings. With the visible deficits or the defects, it's unclear whether it's damage or whether it's wear and tear. Incidentally, we had a few newer devices delivered during the study period, and even after a few uses, we noticed that they did have visible findings in the channel. So are they damaged, or is it just this is part of the normal kind of progression? We also noted that a relatively high rate of visible debris left over despite adherence to manual cleaning, which has been verified on multiple occasions at our institution by our technicians. So this raised a question about whether the current recommended manual cleaning steps are actually adequate if we're still seeing leftover debris within the channel despite following every step to the T. And then finally, with the moisture issue, we were reassured about our drying steps, that our scopes do at least visibly appear dry with a relatively simple forced air dry with filtered medical air. which should be performed because moisture, leftover debris, all of these different findings are potentially risks for biofilm formation and failed reprocessing. So the study was interesting in that we found these things, but also raised many new questions to answer.
Very good. Raman, did you have any insights on how this is significant to our reprocessing techniques now and moving forward?
Yeah, so the question is, Lyndon, is, how do we utilize these results? And so there's a couple of ways that you could potentially use these borescopes. One would be to perform an audit of the quality of your manual reprocessing of your technicians. You could periodically say, okay, we're going to have you do this, and we're going to check and see. And that may not have to be after every case. It may be every 10 cases, or once a week, or once a month, or something. So it could be used as a training tool and a quality control mechanism. The other thing that it potentially could also be used for is to assess when instruments may need servicing. This is something that we don't often do, and so that's another potential utilization, is to say you could take a picture utilizing this device, send it to the manufacturer, and say, is this of concern enough? Should we send this back to the shop? Well, the clinical consequence of this is that the concern would be if you have divots. Certainly when you sometimes put your biopsy forceps and it comes out that it curved, or when you're retroflexed and you feel some resistance, it may be that you're creating a notch or indentation in the channel. And the concern might be that the brushes that we use, once there's an indentation, may not get into the crevice deep enough, and there could be potential degree. Again, we had no evidence of any infections or anything during this time, so again, this isn't necessarily correlate with actual bacterial counts or anything like that, but it may be an intermediate step to help determine the adequacy and quality of a reprocessing. Two final major take-homes. One is, as Adarsh mentioned, we did not see simethicone residue in any of the scopes, the nearly 100 scopes that we, examinations, that we performed on a combination of gastroscopes, colonoscopes, linear echoendoscopes, and ERCP scopes. We did not see that at all. And we also showed that the importance and efficacy of a short medical air dry. None of the scopes that we had, just a short medical air dry with a forced air, had any moisture in it whatsoever. And that may show that may be an efficient way to adequately dry our scopes, but still allow for a quick reprocessing turnover.
Excellent. And you mentioned debris. Does that equate to biofilms? Is that is something within the scope of borescopes, or something?
Yeah, the debris sometimes is unclear. It could even just be a little piece of the channel that could have just coiled up and so forth. So it's not necessarily a bioburden.
Okay.
And we did not, compared to prior images of what biofilm appears, we did not appear to have any biofilm on ours, but it seemed just, sometimes just little particulate matter. It's unclear if that's dust or material from hanging or other things. It's not clear what the clinical consequence is. So, so this sort of raises in some ways more questions than answers in some, but it may be a potential tool again to sort of validate either the adequacy of reprocessing or drying.
Okay. One final note is if you have any future directions in research you are interested in.
Sure. We outlined in the manuscript some suggested studies that really should be performed before borescope inspection is going to be used widely and routinely. And by far the most important thing is that the clinical significance of any of these findings is unclear. We had no infections to patients to our knowledge during the time of the study. Some of the suggested things would be correlating the visible findings with objective findings. People have proposed ATP testing, they've proposed culturing of the devices as we do now, but potentially even doing targeted sampling or using fluorescent markers of the divots and scratches and things like that, or targeted sampling of the debris to see if they actually represent any type of microbiological content. So applying clinical significance to the findings is by far the most important next step. In addition to that, how to use the borescope device. Either use it at the end of reprocessing like we did here, but perhaps instead it should be used as a periodic audit, maybe every few months, to determine the scopes that need to be sent back for repair, or even using it as an intermediate step in manual cleaning to ensure that all the debris is actually being removed with the brushes. So it's unclear how to use these devices, and that should be established. And then finally, some of the questions that we had looked as secondary outcomes, such as simethicone and drying, really warrant focused studies, which could have clinical impacts in the future. So there's still a lot more work to be done before we would consider this a routine device to use.
Thank you. Well, Raman, Adarsh, thank you so much for sharing your study with us. We appreciate your time. Thank you.